So do we have any questions from the audience? Please.
On a different note, can we use the same approach to develop somebody with the sinusitis developing an abscess, like medially based abscess or intraconal abscess? Supposing if you drain somebody with the external approach or a subperiosteal abscess, and the patient goes on developing any abscess inside.
Who's that for?
It's a different note.
Are you asking
with complications?
Are you asking with the precurricular approach?
Yeah.
I was very tempted, but the risk is then you have that pus draining directly into the eye and causing other potential problem, keratitis and things like that. So I have not done, I still do it endonasally rather, and just decompress it medial component. I don't think the precurricular approach should be good for that, for those reasons. Sorry, I can't hear.
Yeah. There have been the subperiosteal component
sure.
has been dealt with.
Definitely, I agree.
If they go further progression and going for intraconal abscess in those situations.
Yes. Later on this afternoon, you'll see the advantages of using the precurricular approach to other orbital lesions. Yeah, for sure, intraconal lesions.
And when you anterior ethmoidal artery, if it bleeds when you're doing this kind of approach, how would you deal with it?
No, so the anterior ethmoidal artery, not for sphenoid wing meningiomas, really. I mean, you have to cauterize the anterior ethmoidal artery. In fact, you see more than just the anterior and the posterior ethmoidal artery, but as Chris Moe described, a middle or accessory artery. It's really easy to find it. So the endoscopic anatomy, which we'll show this afternoon, the first little structure you find is something called the Horner's muscle. And you just follow the Horner's muscle back 12 millimeters at the level of the nasion. You'll find your anterior ethmoidal artery. And you can use standard bipolar forceps to cauterize that. So controlling your ethmoidal arteries takes you 3-4 minutes with this approach.
For the cases of meningioma that involve the optic or orbital apex, is it enough to decompress the optic canal, the bony optic canal, or you should also incise the sheath, the optic sheath?
So we did not incise the sheath in any of our patients, and all patients had an improvement in vision except 2 that had no light perception for a long time. One of those patients could only count fingers for a couple of months, and they went up to vision, I think 6 out of 18, within 48 hours. And that's without incising the sheath.
And there is, according to the literature, there is not any proof that the incision of the optic sheath is really provides a better result.
Any other questions, comments?
Can I ask Ben one? Ben? So, well, I think that landmark, the inframedial trunk is really relatively easy to find endoscopically. How do you plan that preoperatively? Do you get specific imaging that helps you identify that? Because, well, I think the staging system is terrific. I think preoperative evaluation of that, I still am a little bit unclear on.
Yeah, so we're actually looking at ways to identify that preoperatively, and it turns out that on CT with contrast, you can actually see the takeoff. It's actually easier to see it on CT than MRI for whatever reason. But I think what I would stress is that the staging system is compartmental. You're not really looking for the specific trunk, but what you can tell based on the imaging is where the epicenter of the tumor is. So typically what you really should be looking at is the tumor epicenter in the apex and pushing all those structures away from it anteriorly versus is the epicenter more in the anterorbit pushing things backwards. So I think the trunk is a useful landmark because functionally, again, that is the basis of the arterial supply to the medial inferior rectus. But I think, more practically speaking, if you just look at the epicenter of the tumor, that'll give you a little bit more sort of practical understanding of which compartment you should think about the tumor in.
Can I ask the panel about proptosis? So in removing so much volume in maybe Darlene in a sphenoid wing meningioma, why does it not make that much difference to proptosis?
Well, in all our cases, it's because of the intraorbital component. So if you look at the literature, and that's the controversial issue, is how aggressively do you go after that intraorbital component if you've got a benign tumor and the patient still has normal function or normal movement of that eye. So I think that's the next step where we need to investigate. Do we go after it aggressively early? Do we wait until patients have problems? Do we give them radiotherapy? Or is there extra tools? Are there extra tools that we can use, like ultrasound, where we can really clearly differentiate tumor from the lateral rectus muscle?
I think that the question is that if the intraconal is extra, the intraorbital involvement is extraconal or not, and especially in that position, because removing the periorbita, I think it's not a major issue, and you can go close to the lateral rectus muscle. And sometimes we have done something like this. The main aspect is that given the fact there are benign tumors, too much aggressiveness inside of the intraconal, I don't think it's advisable. So it's a wise policy to wait, because the pathology itself in that position is not so curable, and so we have to follow this patient. We started some years ago, and some not. I would discuss about the indication. I'm in love with the transorbital for sphenoorbital meningiomas, but I would discuss seriously with neurosurgeons that have a long experience, better than us, longer than us, which is the best option for the patients. So probably some patients I would operate not again. And so I think that time, if we look seriously at our series and of Professor Lobe is the same for sure, we will see which is the best candidate for this approach. The approach is one thing, is the biological behavior of the disease is another.
And we have other patients that go for cosmetic purposes for any further surgery, and then they end up with double vision.
Yeah, and I would say from the opposite side, after these intraconal dissections, you lose a lot of orbital volume, so you're dealing with enophthalmos and the diplopia that can result from that. And that's why we're strong advocates of doing reconstruction at the time of surgery, but semi-rigid reconstruction. Particularly for intraconal tumors, one of the concerns of doing traditional rigid titanium or med-pore reconstruction is that you can develop an orbital compartment syndrome because you have a lot of edema and fluid transudation. So the reason we use the septal flap is it gives you that sort of early sort of soft reconstruction and then contracts over time. And that works in the majority of patients.
May I have a question for you? Just do you always spare, if I understand, most of the time the periorbita and the lateral approach in sphenoorbital meningioma, or you are going to at least damage in order to reduce the risk of intraorbital increase of the pressure or something like this? It's just
So we are almost starting the study over now, looking for primary cases where we can get as complete resection as possible. So if the periorbiter is involved, which it will be in most cases, we take the periorbiter because we want to do the decompression in any case, so we incise the periorbiter. Your problem is around the superior orbital fissure with this tumor. Really, it's difficult it's impossible to see tumor from nerves. And I think, as you said, if you almost do a cosmetic procedure for someone with proptosis, if they now have diplopia afterwards as well, you haven't achieved what you wanted to.
So we will see what happens.
Thank you very much. We're going to thank the panel for an absolutely amazing presentation.